Welcome to yet another video on how to interpret a complete blood count, a CBC. Today we are going to look at the red blood cell parameter, and today we are going to make sure we interpret what the decreased red blood cell count denotes, what increased red blood cell also shows. So please make sure you subscribe. Make sure you share this video. You can also comment and tell us what more you want. So today we are going to start with the normal hemoglobin levels. For example, when we're talking about a man should have greater than 13 grams per deciliter of hemoglobin levels. A woman should have greater than 12 grams per deciliter of hemoglobin levels, and a pregnant woman should have more than 11 grams per deciliter of hemoglobin levels, and a child should have more than 11.5 grams per deciliter of hemoglobin levels. Now, terms you see on the CBC. When you receive a CBC, you will see mean corpuscular volume. This is denoted as MCV on the CBC, and this is just a measure of the average red blood cell size. The normal range is 80 to 99 femtoliters. Of course, you will see it will either be high or low, or it will be in the normal range. You will also see what we call the mean corpuscular hemoglobin concentration, denoted as MCHC, and it is just the measure of the concentration of hemoglobin in a given volume of packed red blood cells. And the normal range is 32 to 36 grams per deciliter, and all this when we are measuring the oxygen carrying capacity of a red blood cell. And also this information can also give us on the view on any deformity. So we have the mean corpuscular hemoglobin, denoted as MCH, and this is just the average mass of hemoglobin per red blood cell. It ranges 27 to 31 picogram per cell. Let's talk about low red blood cell count, or what we call anemia. Anemia is just a condition characterized by inadequate blood hemoglobin. Usually the lifespan of red blood cell is 120 days, but in certain situations the lifespan of the red blood cell could be shortened either by hemolysis or an acute loss, and some other genetic variations, as we're going to see in the future or as the video runs. So stick with me, please. Don't forget to subscribe. Let us grade anemia. Now, anemia is graded grade 1, grade 2, grade 3. Now, grade 1, this is where you have the hemoglobin levels of 10 grams per deciliter. That's what we call mild anemia. And grade 2, this is where the hemoglobin levels range from 7 to 10 grams per deciliter, and this is what we call moderate. Now, below 7, this is what we call grade 3 anemia. This is where you have below 7 grams per deciliter of hemoglobin levels. And what are the causes? As I told you, the causes of decreased red blood cell could be decreased production. Let me say, if you are taking chemotherapy, this can also lead to pancytopenia, as we shall see in the future. Increased destruction of red blood cell, yes, it could be some drugs. It could be in sickle cell disease, where the sickle cell red blood cells are being destroyed in the spleen. It could be an acute loss. Let me say you have peptic ulcer disease. You could have got an accident. Also, ladies who are in menstruation, they could lose some red blood cell. Idiopathic, whereby we don't understand exactly what's going on with you, but of course we find out. Hereditary spherocytosis, as we shall be seeing, what we call hemoglobin C disease, and also glucose 6-phosphate dehydrogenase deficiency. And bone marrow depression, yes, it can also occur, as I said, when you are taking some chemotherapy. Clinical features. Clinical features, yes, please take note of the illustrations and the background. Of course, some of them they show, for example, let us start with clinical features. We have what we call pallor of the conjunctiva, or the mucous membrane, palms and soles. Of course, we have fatigue. It's also another clinical feature. The patient will come with dizziness, palpitation, anorexia, low exercise intolerance. There is signs of heart failure if severe. Edema in the lower limbs, as you can see in the illustration at the back. We have pitting edema. We have dyspnea, tachycardia, and heart murmurs. And if it is due to acute loss, we have postural hypotension, decreased cardiac output, tachycardia, sweating, restlessness, and thirsty. You can also look for signs of specific pathology, e.g. splenomegaly. We can look for malaria. There is nutrition deficiency or hemolytic jaundice, the way you see our young kid, our young patient at the back. Investigations, definitely we carry out a CBC, the one we are explaining, the one we are trying to understand what it means. You can also do evaluation of the patient. This is physical examination or medication history. We also have peripheral blood smears done under the microscope. And what you have to note is that anemia is not usually the final diagnosis. Careful history, physical examination, and laboratory tests are essential to determine the cause. Classification of anemia. Now, anemia is classified on two grounds. One, on the basis of cause. One, it could be hypoproliferative, resulting from defective red blood cell production. It could also be hemorrhagic, resulting from red blood cell loss. And it could also be hemolytic anemia, resulting from red blood cell destruction. As I told you, we have conditions such as glucose 6-phosphate dehydrogenase deficiency. This one, when we talk about the pentose monophosphate pathway, we shall go more into details with it. But glucose 6-phosphate dehydrogenase is an enzyme involved in this pathway, and deficiency of these enzymes can lead to free radical mediated oxidative damage of red blood cell, which in turn can cause hemolysis. This one is genetic. It is an X-linked recessive disorder, hence it mostly affects smell. We have hemoglobin C disease, which is also a common structural hemoglobin variant. And a person with hemoglobin C trait can show no symptoms, but a person with hemoglobin C disease may have a mild degree of hemolytic anemia and a sequence of hemolysis, including jaundice, gallstones, splenomegaly, among the others. Yes, the second basis, we can classify anemia on the basis of morphology, and here we have what we call microcytic anemia, whereby the cells are smaller than normal, and 80 femtoliters. It could be macrocytic anemia, where the cells are larger than normal, i.e. over 100 femtoliters. It could be normocytic anemia, where you have normal red blood cell size ranging from 80 to 99 femtoliters, but you either have an acute loss, let me say you've had an injury, or you are having prolonged menstrual periods, or you are having acute chronic PUD. What is microcytic anemia? As we said, this is whereby the cells are smaller than the normal size, and this usually occurs in iron deficiency and ineffective red blood cell production as a result of hemoglobin synthesis failure or insufficiency. Cells smaller than normal. As we can see, what are the causes of microcytic anemias? We saw the other side. It could be poor nutritional intake and chronic blood loss, e.g. prolonged or excessive menstrual periods. We have chronic GIT bleeding. What are the clinical features? As per the general anemia symptoms, plus sour tongue, atrophy of the lingual papilla, we have erosion of the corner of the mouth, we can have brittle, fragile fingernails. There is what we call koilonychia, which is spoon-shaped nails, or swelling of the whole body. What is the management of microcytic anemia? Definitely for adults, what we do, we can give them oral ferrous sulfate 200 milligrams, or we can give them FeFo, that is folic acid, and ferrous sulfate 200 milligrams and 0.4 milligrams of folic acid every 8 hours, which is equivalent to 180 milligrams elemental iron per day. To children, we give them 5 milligrams per kilogram, maximum 200 milligrams of ferrous sulfate every 8 hourly. And this is what we need to note, is that the side effects of iron include diarrhea, abdominal discomfort, constipation, black stool. Hence, when you give this medicine to the patient, please, you warn them so that they do not worry about any of these symptoms. Megaloblastic anemia, or what we can term as macrocytic anemia. Here, this is characterized by vitamin B12 deficiency as well as folic acid deficiency. Yes, it has two types. We have what we call pernicious anemia, which is a lack of vitamin B12, or it could be a folate deficiency anemia, where we lack some folates in our diet. So the causes, of course, we have low diet intake of folates, or an increased demand in children and also in pregnancy. That's why we add them as a supplement in pregnancy. So we have low dietary intake of vitamin B12, especially in exclusively vegetarian diets. We have what we call malabsorption of folates and vitamin B12, and also some medicines can lead to decreased vitamins. For example, metformin can also reduce on the vitamin B12, zidovudine, hydroxyurea, stavudine, and phentoin. What are the clinical features? The clinical features of megaloblastic, we have tingling and numbness of the hand and feet. We have muscle weakness. We have neurologic problems such as dementia, depression, memory loss. We have headaches. Someone who could have slight jaundice, which is the yellowing of the conjunctiva. And what is the management? The management, here you can treat the underlying cause. Yes, if someone is lacking some folates in the diet, or someone is lacking some vitamin B12, you can propagate and you increase on the vitamin B12 in the diet. So we have a dietary modification, definitely. Or you can give some folic acid, which is 5 milligrams daily, until the hemoglobin levels return to the normal. Vitamin B12, 1 milligram IM daily for 5 days. Then you can give it weekly for further 3 doses. Now, there is what we call normocytic anemia. This is where you have normal red blood cell size, but they are so small. And what could be the causes? The cause could be acute blood loss, as I told you. If you have prolonged periods, or if you have chronic GIT bleeding, this could be also the cause. Some other causes, we have hemolysis, such as autoimmune disease, hypersplenism, in sickle cell, thalassemia, and also some drugs could lead to this, such as sulfonamides, dapsone, and primaquine. Yes, decreased reticulocytosis, that is the formation of new red blood cell, could also be one of the cause. Clinical features and treatment. General features of anemia, definitely we've seen them. You can feel free to recap and get a grip on all of them. Yes, we have, you can identify and treat the cause of this. If it is chronic GIT bleeding, please, you can try to treat and see that the patient does not continue having those peptic ulcers. If it was the H. pylori that is increasing on the size of these wounds, you could give the triple therapy. If the person is having chronic pain and uses NSAIDs, you can give other alternatives like the COX-2, or you can give analgesics. If the person is having a prolonged period, you can consider, if the problem is with hormonal imbalances, we can try balancing the hormones. If the person is just having PCOS, that is polycystic ovarian syndrome, we can manage that one because it can also lead to overbleeding. Okay, all right. Or you can give folic acid in hemolytic anemia, and definitely we go to what we call aplastic anemia. Now, aplastic anemia, it is rare but a serious disorder. Here the bone marrow stops making enough red blood cell, and this can be because the bone marrow stem are either damaged. What are the causes? Now, the causes could be exposure to toxic substances such as arsenic acid, benzene. It could be cancer chemotherapy. It could be use of certain drugs. It could be an autoimmune disorder such as rheumatoid arthritis. It could be a viral infection, e.g. hepatitis, HIV, damage to the stem cells in the bone marrow. And now what we need to understand is what are the signs and symptoms. Definitely we have what we call pancytopenia, where is the condition characterized by decreased white blood cell, red blood cell, and also the platelets. We could have fatigue and restlessness. The patient comes with hypoxemia. The patient comes with irregular heartbeat. There is heart murmur, pale skin, gum and nail beds. Then we have fever, frequent infections due to leukocytopenia, and there is also what we call increased bleeding tendency. Yes, how do you manage these symptoms? Now, these symptoms are managed by either blood transfusion. You can also give medicines such as erythropoietin to stimulate red blood cell production. Yes, we have what we call hemolytic anemia. Hemolytic anemia, as you can see in the background, please take note of the background. I've tried to illustrate what I'm talking about here. This is characterized by the rupture of the red blood cell before the normal lifespan. And what it can be either inherited, where the parent can pass the gene for the condition to the baby, e.g. in sickle cell disease or in thalassemia, or it could be acquired, where the baby is not born with a condition, but then it develops due to another disease or condition or any factor. What are the types? The types, we have what we call extrinsic, where it develops when the spleen traps and destroys normal red blood cell due to a tumor or an autoimmune condition. Or it could be intrinsic, where the red blood cell produced do not work properly. So yes, here we come. How do you manage? Now, in management, here what we do, if it's an autoimmune disease, we have to give an immunosuppressant, e.g. infliximab or cyclosporin. We can give vitamin supplements, we can give folic acid, we can give epoetin alpha, we can give plasma pheresis. And yes, we talked about increased red blood cell, for example in secondary polycythemia, where the number of red blood cell is increased due to an underlying condition such as myeloproliferative disease, what we call polycythemia vera, in which there is an elevated levels of white blood cell, reduced it most often develops in response to chronic hypoxemia, which triggers an increased production of erythropoietin by the kidney. Most common causes, yes, we have obstructive sleep apnea or Betty hypoventilation syndrome, we have COPD. Other causes, we have testosterone replacement therapy, heavy cigarette smoking, patients who have anterior venosus or intracardial shunting. We have erythropoietin secreting tumors. All these can also lead to increased red blood cell count. So as a patient, or actually as a doctor, you see increased red blood cell count, this could be one of the features that are causing that. So yes, please, if this information was useful to you, make sure you give us a thumbs up. Make sure you comment and tell us where we need to improve or where we need to go next. Please share this video, subscribe, follow us. Yeah, bye bye.